Thank you so much, Lynette, and just want to thank you and organizers. Thank you, Jabulile, for the invite. It's really an honor and privilege to be able to share with you tonight. I've got a few slides that I'll be sharing, so I will try and project from my side. And I'd like to greet everyone who has joined tonight. I hope you'll find the presentation meaningful as we try and raise some awareness, looking at the impact of the pandemic on what it has done to cancer screenings. So I've already been introduced, so I'm just going to go straight ahead. And I'd like to also greet my fellow panelists, the other people who are participating here. And really, it is a great honor and privilege to be sharing alongside such esteemed, panelists. So let me try now and move my slides. This slide is really just giving a high level. I think most people who are on this call probably know what cancer is, but I just thought it's important for us to recap and just understand exactly what we're talking about today and why it is important for us to speak about it and how we can, look after ourselves and also do the necessary screenings and which cancers do we actually have to screen for. So cancer is a disease in which some of the body's cells grow uncontrollably and they spread to other parts of the body. In most instances, the cancers in early stages, they are confined to the organ of origin and, we call them localized, and therefore they are still easier to manage if you catch them early, so you can cut it off specifically if it's a solid tumor or a tumor that happens on your skin or on some of the organs of the body. So the reason why we therefore speak about screening is because when you find it early, still localized and not spread to some parts of your body, it becomes much more easier to manage. We speak about cancerous tumors that spread, and I spoke about that too. Either it can invade nearby tissues or it can travel to distant places in the body to form new tumors. And this process is called metastases. So we speak about metastatic disease, meaning that this is cancers that have spread to other parts of the bodies. We know that some cancers will originate elsewhere and they spread to the lungs, they spread to the liver, they spread to our spinal cords, they spread to the vertebra. So they really can spread and cause more damage to our bodies. And usually that's what we would like to prevent by early detection of cancers. So cancers that have got this ability to actually spread, we call them cancerous tumors, and they are called, the other word or terminology that we use is malignant tumors. So this is the terminology that we use, but it's important for us to understand that there are certain tumors that we call benign, meaning that they don't actually cause a great damage as cancerous tumors would, and those ones are easier to manage and really much less in terms of death and morbidity that relates to it. So the reason why then we need to screen is because screening refers to taking a test that looks for cancer in people who don't have any symptoms. So if you wait until you have symptoms, for most of the cancers, by the time you become symptomatic, it means that cancer has actually spread, or that cancer, even if it's still localized, but it has grown to an extent that it is now starting to cause some level of discomfort. So we're saying we need to screen before you can actually experience any symptoms, because usually that's the time when it is still easy for us to be able to manage the cancer. So the benefits of screening, though, need to be weighed against any risks that the test may bring. Some of the risks that we speak about in terms of screening, we want a test that is going to pick up cancer when cancer is there and also exclude cancer when cancer is not there. So we don't want to give you a diagnosis that is false. And some of the risks with some of the tests, if it's not that accurate, is that it can give you a false positive test result. So that's why we always look at the benefits. So if the benefit is such that we're able to pick up these cancers early in the majority of people, even if in the minority we may miss something here and there, but we're saying in the main, we are able to pick up the cancers and be able to manage them as early as possible. So not all cancers, have got recommended screening tests or programs. And therefore, it's important for us to know which cancers have got these available screening tests and how do these actually work. So in globally, in general, we speak about 4 main cancers that have got some form of screening program in place. So we speak about breast, cervical, colorectal, and lung cancer. So breast, I think everyone knows where the breasts are. Cervical means we're speaking about cancers that occur at the mouth of the womb, which is the cervix. So at the mouth of the womb, so not for the whole womb, just at the mouth of the womb, which is the cervix. And then colorectal means your colon and also the rectum towards a passage of, towards the anus. So that's your big intestine, if we can call it that. So those are the cancers that usually affect the big colon and the rectum. And then there are lung cancers. I think that's self-explanatory because it affects the lungs. In South Africa right now, we do not have national programs per se, but we know that I think breast cancer awareness is there, cervical cancer screening is available in the public sector. Colorectal cancer, not well established, there aren't proper screening programs in place. We do offer some screening benefits in the private sector, which I'm going to just touch on briefly. And then prostate cancer, as much as there's been great awareness in the past around prostate cancer, the recommendation here is that this must be done in discussion with a healthcare professional, weighing the benefits and risks of screening, because there have been some concerns that some of the cancers may be slow progressing, maybe may not really cause harm, and therefore the harm of over treating is what needs to be balanced here. So definitely in consultation with one's clinician, they can still offer a screening. So what are the benefits therefore of cancer screening? Understanding now that these are some of the recommended cancers screening, in fact, these are some of the conditions that we need to screen for. But maybe before I go into the details of the benefits here, because I've not mentioned all the cancers that you've heard about, how then can you be aware that, let's say you've got ovarian cancer, you've got other forms of cancer? So I would say, because there may not be a screening test, but as part of your normal routine medical examination, so when you go and see your doctor may want to test and look at you and examine for any abnormalities in the various systems of your body. So some of the tests, some of the cancers may be picked up during routine examination through your healthcare professional. And also, if you see some changes, for example, people who are prone to skin cancers, if you start seeing moles that are changing in color, definitely you need to go, or they're growing in size, they're starting to bleed, you need to go and get those checked. And we know that people who are fair-skinned, there are specific, skin types that are more prone to skin cancers, family history of cancers. So people, usually are very aware and sensitized to some of the cancers that they may be predisposed to. But there may be other people who are not even aware that they are at risk of cancer. But as part of that routine medical examination, and also when you start seeing certain things that are different, your body changes, you pick up certain lumps, or suddenly you are an elderly person who is 70 years old, you stopped menstruating when you were 50, suddenly you start bleeding. It could be endometrial cancer, which is cancer of the womb. So all these other small signs that could indicate that something is wrong. Even if you don't have a formal screening program, we still recommend that people do go and get checked. So we know that the benefits of screening really is that advanced cancer firstly is not only associated with poorer clinical outcomes, meaning that, even if, people do survive, it may be that, they may go through significant treatments that may impact their quality of life. But, advanced cancers are also associated with higher healthcare costs, almost 3 times higher than the costs associated with the treatment of a localized disease. So here I'm looking at 3 cancers, cervical cancer. I think most people are aware of cervical cancer. Like I explained, it's the mouth of the womb. So we know that 5-year survival rates for women diagnosed with advanced stage is really at the level of 15%. Whereas if you think about early diagnosis and treatment of cervical cancer, we can see about 93% of those people, diagnosed with when the cancer is not spread according to the American Cancer Society. So your 5-year survival is sitting at 93% if the cancer is picked up early. Breast cancer, similarly, if you delay breast cancer treatment by more than 3 months, so it means you're not diagnosed early, you can actually end up then getting more advanced disease stage at the time when you get the diagnosis, which is associated with poorer survival outcomes. While the 5-year survival rate for women with smaller tumors at diagnosis is reported to be close to 100%, meaning that they are treatable and therefore people can actually do better if they are picked up early. Colorectal cancer, like I said, it is one of those cancers that we believe very strongly that early detection of these cancers can actually improve survival and patient outcomes. So colorectal cancer, if diagnosed at an early stage before it has spread, it has got a 5-year survival rate of about 90%. But when the cancer has spread outside the colon or rectum, survival rates have been reported to be much, much lower. So what are the tests that therefore we recommend? So if we think about cervical cancer, a lot of people will know about pap smears. Pap smears, you go to your doctor, they, scrape the mouth of the womb, they put, that on a slide, or if they're using the liquid-based methodology, they put the brush after brushing the cells from the cervix, and they put that, and it goes to the lab for analysis. This usually is not a painful test. It's not, it may be a bit uncomfortable because somebody's obviously fiddling there, but it is a test that is relatively well tolerated. Average risk women, we say you can do this test if you've never had an abnormal pap smear before. You can do it every 3 years. But if you are HIV positive or you have had an abnormal pap smear before, it is recommended that you do this annually. We recommend starting at least from the age of 25. It may be earlier if there is a recommendation, and you can move on up to 65 years. But for women who are older, who have never had a test before, the upper limit of the age does not really matter if it is the first time that they are getting screened. HPV screening is a human papilloma virus, which is a virus that is associated with cervical cancer. There are specific subtypes that we look for. So these are then, we do the test to actually pick up this virus that is associated with cancer. And, once this has been picked up, then, we can decide, are you already experiencing certain changes in your cells? And sometimes then they can follow it up with a pap smear. For this type of screening, if you don't have any problems, you can do it every 5 years. I think right now this is now available in the public sector, and we are also, approving these from the private sector side. Breast cancer, I think the gold standard is really mammography, and in our setting, specifically in the private sector, you find that it is a combined mammography ultrasound testing that is provided. And mammography, obviously, it is recommended mainly in older women, and ultrasound usually in younger women where they've got much more fleshier breasts to actually pick up some of these potentially cancerous lumps. And then for some women who are at very high risk of cancers, there may be an MRI that is required for routine screening, but this is not for everyone. The gold standard and the baseline test is usually mammography and ultrasound. We do also recommend that people be able to at least identify, and be able to familiarize themselves with their own breasts, to understand when there are changes in the size of the breast, the look of the breasts, and also if they start determining that there may be lumps. There's one clinician who is, doing a lot of breast cancer work. She always says, but we must always remember that hens don't have eyes, and therefore, you may miss certain things. So while it is an important baseline tool for you to be able to understand how your breasts look and to be able to do some self-examinations, but you must not only rely on that, you must use these recommended tests. Colorectal cancer, usually the baseline that would recommend for people who are not at high risk for colorectal cancer is for them to go to their doctors. Right now, we are working with some of the labs to create other accessible ways of collecting some of these specimens, because you have to collect your stool, and the stool is then sent to the lab. And in the stool, we're looking for small evidence of bleeding that may be coming from the bowel, and this may be an indicator that there is a cancer that's sitting there. And then the gold standard still here is colonoscopy. I've just put colonoscopy, but there's other forms like sigmoidoscopy, which does not, go as far as what a colonoscope will do. So colonoscopy is really a camera that looks inside the bowel to see if there are some, tumors there. Some people, if just to give a sense of what else people could look out for before you even do your stool-based test or your colonoscopy. If you've got changes in bowel movement, suddenly you get severely constipated, and sometimes you get very loose stools. If there are some of those things, you start seeing some bleeding, you need to just be aware that you do need to get an assessment so that we can pick up colorectal cancer early. So at Discovery, what have we seen during the pandemic? We've seen that registrations on the oncology benefit were down, and we remember and we know that registration on the oncology benefit, which is our cancer benefit, are a function of screenings that have gone down. And the reduced screenings result in delayed diagnosis and initiation of treatment. And I think what we noticed that because some of the services during the pandemic were deprioritized, including, some of the elective surgical procedures where, you would go and have your biopsy. So you've got a lump and then it goes and gets cut. You find that those surgical procedures were potentially deprioritized, and therefore there may have been delays in diagnosis. And, screenings were also deprioritized, meaning that people were not able to access these services, even though some of the services, because of their understanding of the importance of screening, they tried to make these, services very safe, and they still recommended people to go through even during the pandemic. And we know that we started with a baseline of screening rates that were very low pre-pandemic. So the pandemic didn't make things better. Like I'm saying, we were already starting at a low base. If you think about Discovery with a very well-structured wellness program like Vitality, where we incentivize people to screen, our screening rates are relatively higher than the rest of the industry. But we are still hovering in the lower, with the breast cancer screenings below 30%, we look at our high screening rates are currently sitting in the cervical space, but they are still sitting below 50%. So I think we are saying we started at a low base. Colorectal, I'm not gonna even speak about those rates. They're much, much lower. And therefore, we do need to think about how we improve screening, because our concern around lower levels of screening is that we will start seeing that shift to advanced disease. And that is therefore associated with lower survival rates and higher costs of treatment. And I'm going to share some data now with you. So this is the 16% reduction in oncology registrations that we saw. And I say, because you're not screening, you're not going to see people enrolling on the oncology benefit or the cancer benefit. Mammograms per 1,000 lives, per 1,000 female lives, were down by 17%. As you can see, the biggest drop was during the lockdown level 5, where obviously everyone was at home and people could not prioritize screenings at that time. But even though we did catch up, because of that backlog of the screenings that didn't take place, we were still much lower in 2020 compared to the previous years overall. Similarly, with pap smears per 1,000 lives, per 1,000 female lives, we saw that reduction of 18%, even though we did see a pickup towards the end. But obviously that backlog also meant that in 2020, we still had on average lower levels of screening compared to other years. And we really are hoping that going into 2022, we're going to start ramping up and start seeing more people going for screenings, because we're just worried about the long-term impact. And for colorectal cancer, we just looked at registrations as well. As you can see, there was a reduction there that even though it caught up, there was still that backlog as well. So this is a slide that really shows early data, which we're going to be monitoring over time. As you can see, in 2021, there is already a shift. So you see that, in the prior years, there were more cases in the blue bar, which is stage 1 disease. But what we are seeing now, there is a slight increase in the stages 2 and in the stages 3 to 4. And we're worrying that this trend is going to be a trend that continues, and then it means that a lot of people are going to have advanced disease that's going to be much more difficult to treat, and it may cost people their lives as well. And we've got colleagues who are in the oncology field. They are already seeing some of these shifts towards advanced disease. So what can we do? I think just by coming here today, it's a big step because we're raising the awareness. People are getting aware around screenings. I think we need to create broader awareness campaigns to drive screenings in our own personal spaces. We must also, commit to doing our own personal screenings. I must say I'm also booking my own screenings so that I contribute to driving up screening rates, for all these various cancers where we do have the benefits. And in our discovery environment, we do already have these incentives, but are there additional incentives that we can think about more broadly to drive screenings? And I think, during the pandemic, the biggest thing was really addressing some safety concerns at screening sites, which we say definitely, most of the screening sites had taken COVID precautionary measures into account to ensure ongoing access to screening. And I think we do need to improve access to screening. When I say improve access, it's really like when I was speaking about colorectal cancer, we must make sure that people do not have to be looking around and trying to find places. Places for screening must be easily accessible. When you walk around, even if you were just going, minding your own business, doing something else, it must just be on your face, and you must be able to say, you know what, I might have not thought about screening, but I saw this particular place that was, doing these screenings. I'm definitely going to be part of those people who go there and screen. So I think on that, I would like to thank the organizers, and if there are any questions, I'm happy to address them. But thank you very much, and hopefully in 2022, we'll see a different shift towards more screenings and early diagnosis of cancer. Thank you.